All right. Hello, everybody. So my name is David Richards. I am English, an Englishman living in France, working in Norway. So it's a bit complicated. I speak English as a native speaker, which sometimes I'm used to speaking to international audiences, but sometimes I might speak too quickly or use a word you don't understand. Could you please hold up the red card, like in the football, if you want me to stop and say something, explain it better or say it again in clearer language. It's not a problem for me at all. Like Ricardo says, we try to be informal and friendly in these sessions. So I currently work here in the Western Norway University of Applied Sciences. We're based in Bergen, which is a very beautiful town, but with one problem, which is every 300 days and every year it's raining. So it's not like Lisbon. But it is beautiful, so, come along anytime. And also before most of my career, I worked in England, and I ended up working for 14 years at the University of Exeter, which is a very good university. My background is in nursing and psychological therapies. I'm a psychotherapist as well as a nurse. And for 20 years, 25 years, also what we call a health services researcher. So I think you probably know what that means, which is I don't have a white coat in a laboratory. I'm in the hospitals or the clinics or whatever, looking at how to improve the delivery of health systems. I've mainly worked with psychological therapies, organization, some cardiac rehabilitation, some primary care, and more recently with nursing care, particularly fundamental nursing care. No, you're right. It is very sensitive. Okay. Ricardo gave me these 4 things to do. I'm very careful. I am going to do these 4 things exactly. We're going to understand something about the causal effect. I spend quite a bit of time talking about that because I think in the philosophy of science, we don't spend enough time thinking about how we establish cause and effect. We will, of course, I've never done a pharmacological intervention. I know the principles, but I've only ever done non-pharmaceutical interventions. So we'll talk about the differences briefly. And then I'll move on to bias and introduce some of the new Cochrane collaboration, because they've changed the way they measure bias in trials now. So I'll introduce you that and just talk about what I hope you will find useful about best practices in designing. So that was my task. Let's see if I achieve it. So what is causality? So if you look at dictionaries and think about causality, you can find rather primitive definitions, in my view, of causality. The first one that I found, one of the ones I found was that there's a logical relationship between 2 events. Yeah, so I underlined logical because, events can occur together, but there is no logical reason why they should. So there's a judgment you apply that says there's a logical relationship. And we've got a special name, haven't we, in science between events? We call them variables, which is a way we describe events in research. And there are always 2 types of variable, which you probably know: independent sometimes it works and sometimes it, oh, there we go. Independent and dependent. And it's very important not to get them confused, because an independent variable measures what you think is the causal event, and the dependent variable is what you think is the effect event. I think probably at your advanced stage this is just revision, but important revision nonetheless. Oh, it's so sensitive. It's okay. I'll get used to it. So this is a kind of philosophical exercise you have to go through when you're thinking about cause, and you've got to say, well, how is that relationship be a logical one, rather than, I don't know, it's sunny and I had breakfast. That's a relationship. Those two things are true, but I can't see that there's a logical relationship between it being sunny and me having breakfast. So how do I establish a logical relationship? Better one would be, it's sunny and I feel hot. Well, we have to observe, first of all, this association. And we only call that a correlation. It's just an association between these two events, which we call this special name. And they have to change together, so that when it's not hot, when it's not sunny, I'm not hot, would lead me to think that there is a relationship between sunny and being hot. Because when one goes up or down, the other goes up or down. So we observe these relationships. And this is a very naive view, actually, because in this, I pulled this down from a dictionary. It said the cause always precedes the effect. Yeah, okay, that kind of makes sense, doesn't it? There's a time between one and the other. But there is much, much, much more to this than that simple idea. So, how will we do it better? I'd like to introduce you. Do you know this man? You don't know him? Well, he's dead, so you probably don't. Not personally, but somebody's nodding, so you know about him. He was a medical statistician in the 1950s in England. He's actually called Sir Austin Bradford Hill, because he became quite famous and honoured for that. He's most known for this. Richard Doll, you may know this guy's name. Richard Doll was most famous for pointing out that smoking was related to lung cancer. But Austin Bradford Hill was the statistician that worked with Richard Doll to establish that relationship. And I've got a quote from him, which I like it very much, because he says he's got no wish nor skill to embark upon a philosophical discussion of the meaning of causation. So it's still not that simple. We need to pay attention to it. And of course, he then went on to establish the meaning of causation, even though he said he didn't want to. And if you remember, well, I wasn't even born, so I wouldn't remember, but if you think about the 1950s, we didn't have the same understanding in scientific philosophy to how do we show that the independent variable causes change in the dependent variable. So he came up with some interesting ideas. There. Have you ever heard of the Bradford Hill causation criteria? It sometimes gets taught in basic science courses, but often it doesn't. I think that's really important. And there's a reason why it's really important. So you imagine this this guy with his bow tie, looking, part of the British establishment, and he's trying to think, how do I show that one thing causes another? And he came up with these 8 criteria, which I think are actually worth thinking about in our world now. So he said, what we first need to do in order to strengthen our argument, you can use these arguments in your work, strengthen our argument is it consistent? So do different people in different places experience, and different samples, experience the same thing? So maybe if we were to ask, hundreds of people, do you get hot when it's sunny? Or maybe we should ask a more open question, actually. How does the sun affect your temperature? If they all say, well, when it gets sunny, I get hot. So there's a consistency in the relationship between sunshine, body temperature. So he said, look, if you get the same thing by different people, then there's an argument there that there's a relationship. All he's trying to do, and because he's a statistician, what is his thing? All statisticians, their thing is probability. Right? That's what a statistician spends their life thinking about: probability, the chance, the probability of something happening. And so he'd be saying, well, there's a strong probability sunshine temperature is connected. What about specificity? Now, let's think about something different. He's saying that it's likely. Look, you see, he's using these ideas of probabilities, using these words of probability. He's not saying it is true. He's saying it is likely if in a specific population, disease, or there isn't another likely explanation, the more specific this association, then the bigger the probability, again, bigger the probability of a causal relationship. I like the way he writes. Statisticians always like that. They never say, no, something is or isn't. They say, there's a bigger probability of something being the case. So, if it's specific, you can tick that box. Now, here's the previous quote I gave you. I said it was naive, very naive, but it is one of the things, temporality. Of course, the effect has to happen after the other event, after the cause. But temporality, even though if you just say, what is the definition of causality, you type that into Google or something, it only mentions temporality, doesn't mention these other things. Very naive. Don't believe everything you read in Google. Biological gradient. Well, that's not always true. Sometimes just one thing, there's no gradient. But greater exposure should generally lead to greater incidence. Plausibility. I think that's kind of interesting because it's not required, according to Bradford Hill. We have a lot of pressure on us to involve theory in our work, yeah? So if we're developing an intervention or thinking about our health systems, we're all supposed to have a theory. I don't like theory very much, personally. I'm a pragmatist. I observe things and I like to investigate them. And so I'm with him because he says it's not required. So, for example, the presence of a virus and forms of cancer in the same person, you may not have a mechanism that you know about that connects the virus to the cancer. You just know that they appear in the same person. So now we're knowing much more about this, but when we first started observing virus and cancers together, we didn't really know how they might one might produce the, the changes in the cells that causes cancers to grow. So, but nonetheless, if there is a relationship and it's plausible, we can use that as another one. Coherence. Well, this is where what we observe in the real world and what you play around with in a laboratory connect together and look like that they are doing similar things. So between epidemiological and laboratory findings, there's a coherence. Look at this. We're going to spend the next day and a half talking about clinical trials, which is a form of experiment. According to Bradford Hill, it's only 1 out of 8 ways you can argue causation. So even though I'm a completely confirmed clinical trialist, absolutely think we should be doing this, I always try to think about what arguments I might use, and experiments are only one. And he even says it's not always possible. That doesn't mean you shouldn't try if it is possible. Did he do an experiment, a randomized controlled trial about smoking and cancer? Did he do that? I mean, could you do that now? What could you do? Well, let's divide half of you into, give you, free cigarettes for 30, 40 years, and then come back and say hello and see how many of you got cancer and how many didn't. I mean, you wouldn't do that, would you? However, look at the way we regard smoking. We can't smoke indoors. We can't, we've had lots of public health measures to try to reduce smoking. What is it now? I think something 19 or 20% of the population, I think, in England, I think, maybe less. No experiment was ever done to establish the causal relationship between smoking and cancer, because you couldn't, and you wouldn't wish to. And he, ironically, Bradford Hill is one of the driving forces behind the UK's Medical Research Council. When the Medical Research Council was set up, I think he was something like the first statistician in the council or something like this. So he's kind of known as the father of the randomized controlled trial. And here he is saying, well, actually, it's only one of our proofs. And the last one he said, which is really neat, is, can we find an example from somewhere else where the same thing occurs? So air pollution is a good example of an analogy, taking the analogy from smoking, and now, we've got low emission zones in cities, and we know that there's a correlation between deaths and the pollution in cities, and between lung disease and pollution in cities. And the analogy to that, of course, is the original work on smoking. Because nobody's doing, well, actually some people might be, but doing a randomized controlled trial of let's have smoky, dirty cities over here and let's have non-smoky, clean cities over there. Nobody's actually doing that. We're going ahead and putting in low emission zones all over Europe, certainly all over France, where I live. We're banning cars from cities in order to reduce pollution. So the fantastic ideas here, and they are fantastic ideas, and they got forgotten, and now we're all remembering them again. You should do that. When you're spending your time today and afterwards thinking about designing an experiment, think also about what other proofs you might be able to bring into your arguments to suggest that one of these things is related, and in fact might not just be correlated, but might be causal of another variable. So there you go. This is my learning objective from Ricardo. I think I've done pretty well with that, but I've still got more to go. So why would we want to do that? Here's the first quiz. Should you want to establish causality? Why? To replace previous treatments with new ones? to replace current treatments with cheaper ones, to avoid harming people, or to just demonstrate the impact of a novel intervention. So what do you think? Vote now. Hold them up high, I think. Some yellows coming up. Any other colours? Oh, a red, very good. A few reds, yellow. And you got it right. Actually, they're all true. Hey, trick question, thank you. Yeah, of course, we want to establish causality for all those reasons. It depends on what your question is. Oh. No. I'm going to have to look. Is that right? I think so. We're leaping ahead. I think this is the next one. So what about the value of a randomized trial? Well, okay, despite everything I've just said, it is pretty difficult to establish causality through observational research. In the Nordic countries where I work, we have these huge, great registries where we get large numbers of people. So it's a bit like the work that Richard Dolan and Bradford Hill did with smoking. They had a great big register. It was actually a register of doctors. And they were able to use that register in a non-experimental way. So it is possible to derive good arguments for causality from large data sets. Most of us don't have access to those data sets. And many of the situations we're in, we wouldn't be able to use the data set to change anything. So we have to do an experiment. Now, where I've got here observational data, looking at some of your projects, it seems to me that a number of you were collecting observational data. And I've called it numerical or narrative. I don't like the word quantitative or qualitative. It means nothing to me. It's better to describe the data you're collecting, which is either numerical or narrative data, so words or numbers. And it can explore things, it can help explain things, but unless you align that data to experiments around interventions, then you're not going to really be able to get those levels of proofs that we've been talking about to establish causality. To do that, you need an experiment. Okay, and that's what we're going to spend the rest of the time talking about experiments. I'm so cautious. Oh. Right. You're just going to have to bear with me on this one. Okay, everybody, another quiz. Here's some criteria that could be used to describe an experiment. Okay? So there are 4 criteria I've listed. The first one is the manipulation of an independent variable. Second one is the measurement of dependent variables. The presence, the third one, of different intervention and comparison groups. And the fourth one is randomization. So you have 4 choices. You can either say one of them is a definition of an experiment, 2 of those criteria, 3, or all 4. So, hands up, please. Hi, I can't see, honestly. I'm looking, as some people are thinking. You divide. Oh, thank you. Yeah. Easier. Which is that's the pointer. Cool. Thank you. Yes, right. You divide about equally between reds and yellows with a green. Okay, any other colours? No. Right. Well done, sir. Green, in my view, is the right answer, and I'll explain why in a minute. Many of you fell for the trick You yellows, you fell for the trick of describing an experiment as a randomized controlled trial. And in actual fact, if I was being really naughty, I'd say the answer is blue. But there's not much point in manipulating an independent variable if you don't measure its effect. So I agree with you. The criteria for an experiment is that you manipulate an independent variable and you measure the dependent. One of the things that really annoys me, you can tell I'm old. I'm 64 today, right, by the way. I'm kind of cranky. And I don't like the term quasi-experiment, which is often applied to non-randomized controlled trials. That's an experiment, guys. You know, you're manipulating something and you're measuring the outcome of that manipulation. What's quasi about that? It's an experiment. Yeah, let's see how we. Oh, that's much better. So, how many of those research designs are experiments? Given what I've just tried to tell you. 1 of them, 2 of them, 3 of them, or 4 of them? What's the answer? Well, no, but you're taking your time to think. I've got some hands coming up. Any more? Okay, a mixture, but by and large, what I've just observed is more greens than anything else. So 2 of them. And those who suggested there were 2 experiments, which ones are the experiments? Somebody say?
Randomized controlled trials and before-after studies.
Yeah. Okay, well, we solved one problem and caused another. It's just the pointer. I can handle without the pointer. It's better that this is working. That's fine. Yeah, absolutely correct. So the only experiments in this list are the randomized controlled trial, which some of you thought was the definition of an experiment. That's not true. And a before-after study, which some people call a quasi-experimental study, but isn't, of course, because it's an experiment. So there are 2 experiments on this list, the Focus group, and I think maybe some of you got a bit confused perhaps with the cohort study. Cohort studies are generally epidemiological studies without any intervention, where you just observe either backwards or forwards or even cross-sectionally about what's going on, but you don't intervene. So, to set up the whole workshop, what is an experiment? Well, I again did a rather bad thing, you should never do this, I went on to a search engine and I said, right, okay, what is an experiment then? That was one of them, and that was another. And there's probably only 2 important words which I've underlined, which is that you perform a series of actions and you do that intentionally. All right, so there's nothing in there about randomization, is there? Nothing in there about control groups. If you think about it, if I was in a laboratory and I had, some agar solution, and I had a phial, a pipette of a bacterium, and I wanted to see if the bacterium grew on the agar solution, I don't really have to randomize the agar plates to no or yes pipette of bacteria. I just stick the bacteria in the agar solution, and if it grows, it grows. If it doesn't, it doesn't. Okay? So that's an experiment. So it's a series of actions, and you observe the effects, and you do that intentionally. So that's your basic experiment. Okay. Now, I'm not saying, and I will argue against myself, I'm not saying that that's enough. I'm just saying that when you talk about experimental research, all you're doing is intervening and measuring. Okay? That is the definition. Basic experiment. What about a controlled trial? add one more thing. And the thing we add is the presence of independent groups to compare. So perhaps we want to know what dose of bacteria will grow in our agar plates, so we have different doses and we compare the things between each other. So we have an experimental and comparison groups. Okay, so that's the second form of experiment. And we all have that in the randomized controlled trial, and then we add randomization. Okay, so if you think about those 4 criteria, that's what a randomized trial is. Manipulation, measurement, presence of a control, and you randomize the groups to the different comparison groups. Quite simple, really, isn't it? I'm sorry, I'm going right back to basics of science because I think, you know, the way you responded to the what is an experiment question told me that there's a huge misunderstanding in you know, clever and educated groups like you that an experiment means the bottom. It doesn't. An experiment means the top. And why is that important? I'll tell you why it's important. So we did a systematic review published in 2018. It was a bigger review than this. It was about fundamental nursing care, and we wanted to know what actions by nurses were useful for improving, or what effect actions from nurses, let's be open in the question, what effects actions by nurses were in terms of patients' healthcare, outcomes for health. And the interventions were hard to define, but various interventions which we modelled under a theory called the fundamentals of nursing care theory. So I'm just going to show you one part of that. We found 149 experimental studies. So we discounted all the descriptive studies. We wanted experimental studies. And 67 of them were randomized controlled trials. 32 were non-randomized, so there was a comparison group, but there was no randomization. And 50 were uncontrolled. And by that, I mean generally before and after trials in one group. They're all experiments. So 38 of those studies are about hygiene. I'm just going to show you the results and try to answer Ricardo's question, the value of a randomized trial. So here is what we call a harvest plot. I need to explain this, I think. So what we have here is 3 colours. That's the first thing perhaps you notice. The 3 colours are 3 different types of intervention. There are self-care assistance. There's only 3 of those. There is washing and cleaning, where we are cleaning patients as nurses. And then there is oral care. So we included all those. Hey, thank you. Look at this. Right, so 3 types, 3 colours. So that's the first thing you notice. Now, when we looked at these trials, we discovered that people didn't often specify a primary outcome. So we took a decision that said if they measured it, we're going to record it. And what we did is say if there's an outcome in favour of the intervention, you get 1 point on this right-hand side. If there's an outcome that is showing either no effect or in favour of the control, we're on this side. Yeah? The other thing we did, as you can see, is we've got the uncontrolled trials here, the non-randomized controlled trials, and the RCTs. And equally, we did an assessment of their quality. And so we've got these trials, which are uncontrolled, low quality, one here of high quality, same here, and so on. Okay, so if you look at it, if the bar's on the right-hand side, it means this trial is got a positive result in favour of the intervention. If you're on the left-hand side, there's a result which isn't in favour of the intervention, okay? And then you've got different. So, what is happening here? How do you interpret that diagram? Do you think I'll go back and you can have a look. Do you think the interventions are effective? That's you're a blue person. Do you think the interventions are ineffective? You're a green person. Do you think there's no difference? You're a red person. And if you genuinely don't have a clue, be honest. You can put the yellow one up. So here you go. Do you remember the choices? Quickly again. Effective, you're a blue person. Ineffective, you're a green person. No difference, you're a red person. And if you genuinely are completely baffled, you're a yellow person. So where are you? What's happening here? All right. Come on, everybody. We haven't got too much time, so thank you. Yeah, yeah, good. Some yellows. Thank you. That's great. I like honesty. It's the best policy. Come on, everybody. Let's see what you think. There's quite a few people who are terribly confused. There's a couple of three blue people. There's a person you don't know. Yellow person. Yep, yellow. Yeah, totally confused. Yep. I've baffled you all so early on. Okay. I'll show you what's going on. Anybody was a green? Right. What's going on here? We often... You're a late green. That's because you knew the answer. Right. What we often hear is that poor designs and poor delivery of those designs leads us to overestimate the effects of treatment. That's what we see here. You see how the worst design has the best results in favour of the interventions. The best designs, even the low quality ones, show that the intervention... It's very stark here, isn't it? This is the largest group of studies on oral care. We think we know about oral care. Let me tell you, when we did the review, we were horrified because the really good studies on oral care showed no impact of the interventions. And people's practice is based on the really bad studies. So you can do that. You can draw a line that shows the worse the design, the worse the conduct, it's giving you the wrong answer. You do a really nice study, controlling for all kinds of confounders and things, i.e. good quality RCTs, you get the totally different finding from these studies here. Ricardo, the value of a randomized clinical trial? Yeah, got that. Okay. Have I made my case? Actually, unfortunately, these are much more prevalent in my field, nursing, much more prevalent to be able to have really poor quality studies, and we shouldn't believe them. Because when the proper studies, when the nicely controlled studies are done, we often find the opposite result. And this is the starkest example. In the other areas we looked at, they were a bit, either way, couldn't really tell. But this was quite outstanding because it demonstrated the value of properly controlled clinical trials. Right. So that's a summary of what I've just tried to explain. And thank you for being honest about your confusion and not having a clue. Have I explained it adequately? Are we okay now? No? Yes? Yes? Okay, thank you. Cool. Right. So in other words, the more we control for confounders and alternative explanations, the closer to the true effect of the intervention will be. Now, some people, of course, complain, well, the only way you do that is to be so specific that your work cannot be applied to the real world. That's not true either, but that's a common argument we have to face. So what we need in our experiments is randomization and independent comparisons, and that's what this course is about, and that's a very good reason, I think. Oh, I'm going on to objective 2, and I've only got about 20 minutes left. only one slide on this, which is really all trials have many challenges. Any clinical trial is really hard to do, and I cannot underestimate how hard a randomized controlled trial is. It's extremely difficult, and you need to learn hard how to do it. And you can think about methodological, clinical, procedural, and regulatory challenges, all of which you have to address. But non-pharmaceutical interventions, which is what we are mainly dealing with in this group, they have really a lot of additional challenges. And the difficulty of standardizing the design and delivery of the interventions is something, we can do it, but it's something you have to think about differently. You know, it's not the same as putting 75 milligrams of salicylic acid in a pill and handing it out and handing out a placebo. You know, you've got to work a lot harder. Context is really different. I mean, I'm going to spend a little bit of time in the next lecture on that, so I'll move on. Quite often we can't do experimental methods where we've got service or policy change because it affects everybody. So that's really a hard thing to do. And the length and complexity of the causal chains. I think some of you are doing educational studies, educational interventions. Presumably the reason you want to do that is that the people you're educating delivered better or different care. That's a long chain between your intervention and patient care. And then, you know, you might be able to demonstrate changes in education and knowledge and so on, but going further, how do you do that? So that's what we call a causal chain, and it's a long way. And that's different from presenting somebody with a pill. And behaviour change. Mostly what we try to do in our world is promote behaviour change. But even in pharma interventions, that's difficult. And I'll tell you, what is it now? 8 years ago, I had a heart attack. And I've been on some usual drugs. Since then, my cholesterol's brilliant and it's doing good. But I got this little sticky triglyceride result. It doesn't seem to come down as much as I would like. So last year I went to see a cardiologist and he said, no, your drugs are fine, stay on the same drugs. Okay. A few weeks ago I went to see another cardiologist for my annual thing and he gave me a different set of drugs. Still got the big powerful atorvastatin, but it's got a specific lipid lowering compound in it as well. Now it's not a particularly new drug, hasn't come out in the last year, so why didn't the first cardiologist prescribe me that? Knowing what my blood results were, why did I have to go to another one? And that's because it's behaviour change. So even in pharma interventions, getting behaviour change into individual clinicians is still hard. So let's not pretend that pharmaceutical interventions are always simple. Right, let's move on. Sources of bias. Well, how can they be minimised? Well, let's have a look. Have you come across this table before? Yeah, some people are nodding. It's pretty much the classic, it's out of the 2011 Cochrane Handbook. It's pretty much a classic 5 sources of bias, and they use this when they are assessing clinical studies to see if they're reliable or not. Selection, performance, detection, attrition, and reporting. Well, I don't know if you're aware of this, but last year, this has now been superseded. I don't know if it's a success or not. I quite like that. I think it's easy to understand. I think selection, you know, are our groups comparable? Is there a difference between the groups as well as the intervention? Are we measuring in a way that's not biased? Is there the same amount of loss to follow-up in both groups? And how are we reporting it? So they've changed it. They've changed it to this. And I don't know if anybody's involved in the Cochrane collaboration, but I don't find this particularly helpful. Do you? I think it's more complicated. Yeah, but the words they use are not easy for people to understand. So I'm not very happy with them for doing this, I have to say, but I think this is probably going to become the standard. I mean, it's still the same. It's still, still the same kind of areas. Well, the randomization process, that's about groups. The intended interventions, that's about performance bias. But they don't use those words they're all got used to using anymore. And that's because all they do is sit in their offices and read trials. Because they don't go out into the real world. That's not true. But the people that wrote this are not part of the wider Cochrane community. But I think you need to be aware of it. As I say, this is in the 2022 version of the Cochrane Handbook. And there's a source of bias tool associated with this you can download, and you can put the details of your trial in, and it will tell you how biased the trial is or not. So, we better get used to it, unfortunately. Right, so here's a question. Here's a bias question. Come on, let's have some assertive cards coming up. In a randomized controlled trial of a behavioral non-pharmaceutical intervention, who should always be blinded? Participants, clinicians, researchers, or statisticians? Who should always? Keep going, we've got blues, some blues coming up, we've got some reds coming up, blues, a red coming up. Okay, blues, so green, okay. So actually nobody got the right answer. Cool. The right answer is D. Yeah? And the reason for that is that sometimes it's just not possible. If you're doing a behavioural intervention, participants will probably know what they're doing. The clinicians will have to know what they're doing, otherwise they wouldn't be able to deliver it. And sometimes, particularly in cluster randomised trials, even the researchers can't be blinded. I think those of you who put red up, you're pretty generally correct. Let's keep our researchers blind. It's actually quite difficult in some trial designs to do that. But always, you should present the statisticians with a totally blinded data set that does not identify the groups. Okay, so, and this, of course, is the problem in Cochrane criteria, where they ask about blinding, and you're doing a cluster randomized trial of a non-pharmaceutical intervention. The only person that's blinded is the statistician, and you get a really bad mark. How could we do it? Generally, red and yellow are the right answers. So I think the question that we talked about these biases. The question that Ricardo presented me with was, how can we minimize to ensure accurate results? And that's a really important thing to do. And so I think you need to go and have a look at the auditors. What would the auditors say about your trial? And so you go to the Cochrane Risk of Bias, that's the auditor, and you look at their tool and you try to use their tool to identify areas of potential bias in your study and try to do something about it. And it's not just about blinding, it's about everything else. Because there's those 5 criteria. And one of the things I would say strongly is randomization does not reduce many of those biases. Randomization only really reduces selection bias. What reduces all those other biases is you doing a good job. Yeah, you running a high quality trial. Just throwing in randomization into your research design will not reduce performance bias or attrition bias. What will reduce those biases is you really focusing on your procedures. And to be honest with you, in my view, in terms of research, 10% is inspiration, 90% is perspiration. It's like running a ward, it's like running a business, it's just being a great manager, being on top of things. Some biases are caused by weak methods, but basically excellent research procedures is how you're going to do it. So that's one of the beauties of this course, is it's going to teach you excellent research procedures as well as designs. So, final objective. It's going to tell me to shut up in a minute. Final objective is learn best practices for designing and conducting clinical trials. I hope most of you know this stuff, but do you know about this research waste argument? Yeah, you've heard about this before. It's a bit horrifying, isn't it? Who is Ian Chalmers? Anybody know who he is? Well, Ian Chalmers is one of the people that set up the Cochrane collaboration, so he should know about research. I think he's quite up, he's quite knowledgeable. He's quite old as well now, because, I went out for dinner with him once, but he was just as sharp as he'd ever been. And Paul Glazier is a GP, a family doctor. And they said 85% of healthcare research activity is waste. Oh, that's a bit depressing thought. We spend all that time and it's wasteful. And even this is an old article. Other articles have come out subsequently. But he said the reason for that is that we're asking the wrong questions. We use the bad methods. We're not publishing promptly, and we are reporting in a biased way. And they said this horrible thing that most research confers or gives no benefit to people in need of it, which is, yeah, I know. So they said this was the reason for bias. We're asking low priority questions, we're not using the right outcomes, and we don't involve people. So we sit in our offices and we think, this would be a great idea, let's do this. And then, nobody wants to know the answer. And we measure the wrong thing. And if you read this article, it's a good article, 2009, you can find it easily. They give some examples of where we're researching the wrong thing, where the researchers are doing one thing, but the patients with a condition want the researchers to do something else. So what a waste. People with rheumatic and arthritic diseases don't want more research on pain control. They want research on fatigue. That was the thing that bothered them most. And all these researchers just came up doing more and more pain control research. You'll be glad to know, of course, that we have a tool to help us do relevant research. And this is Ensuring Value in Research website. And a lot of research funders have signed up to this. I need to look, actually, whether Portuguese funders have or not, but certainly quite a few of the Nordic ones do. The British ones do. And I don't know the attitude of the European community to this. I should know, but I don't. But I suspect it's not similar. So all they say to you is, look, when you're designing your research, so you want to do some clinical trials, find out what the priorities of the users are before you embark on it. Do a systematic review to discover whether we already know the answer or not. I mean, these are basics, right? But they are critical. Use steps to reduce bias when you measure when you design, and register that at inception so that people have got something to go back on and say, did you do what you said you were going to do? The trial registration is really important now. This I'll spend less time on because, we often argue that non-pharmaceutical research isn't risky in the way that pharmaceutical research is, but actually it can be. Some of our interventions can harm people as well, so we need to be clear about that. This is about reporting, really important. If you want to replicate a trial, which you might want to, is there enough information in the report so that other people can do that? Or if you're a clinician and you want to reduce SALT in the population, can you go to the trial and you find out what they did in every detail possible? Make sure that when you do it, you describe, and there are tools to help you do that. And this is a new thing. I had to do this in an article, the COBRA article, which you've reviewed and we'll talk about tomorrow, we actually had to add the COBRA data to the systematic review data at the end of the paper to see what changes it would make to the specificity of the findings. So we don't do it, do we? We do the systematic review at the beginning. You ever thought of doing the same review at the end, putting your data into the systematic review? See what changes, because that's why you've done the research. And then the best tools are on here. You know about this website? Yeah, the Equator website. This is where you get the reporting criteria for whatever design. When did I look at this? 319. I think that's an old screenshot. There's more than that now. There's about 400 reporting guidelines. It just keeps growing and growing and growing. And I'm not going to spend any time, but if you think about it, why wait until you've done your study before you look at the reporting guidelines? Why not look at all these? This is the most famous one, the consort diagram for RCTs. Why not look at this now when you're designing your study and say, am I identifying the trial in the title? I saw a lot of your proposals. I haven't a clue what you're doing, from the title. I'd want to see your titles that say what your study is, because that's what you're going to have to do when you come to publish it. So you should be doing it right at the beginning. And there's a whole load of other criteria. I'm really not going to go into that. It's no point. But what I am going to show you is that look at this extensions. When you're designing your study, go to the extensions and have a look, because most of these things have got additional criteria now. And you can't really see this, but this is just the consort criteria extension list. This one, randomized controlled trial of social and organizational interventions. We do quite a lot of that in our world. Randomized controlled trial of non-pharmaceutical interventions. We do quite a lot of that. Pragmatic randomized controlled trial. There's quite a lot of overlap. There's even something called a conserve statement. Anybody heard of that one? Yeah, I had to use that one because that is the adaptations you had to make to your randomized controlled trial because of COVID. Because we were all doing trials and they all got screwed up. So we report it. Like design changes, changes in recruitment procedures and so on, which had to all change. So have a look at the extensions, choose the extensions that fits your particular design and use that to design your trial. Simples. Why not? So here you go. My summary for trying to address these this last learning objective is that there are a lot of tools available, so you've no reason to feel alone. You can go to the Cochrane and try to design bias out. You can go to the reporting criteria and put the right things into your trial before you report it. Oh, I hadn't thought about allocation concealment. Who's going to do the randomization? How will we keep that secret from the guys on the ground? There are all these things which really help you think about stuff when you're in the design phase. Have a look at the ensuring value in research, which is a broader thing, which is about how you're describing the intervention. Is your focus supported by users of the research? How will your impact affect those users? How will I write up this trial so that people can replicate it? Really good things to do. And then you can do this too, which is coming later, because that is probably the most useful tool in your toolbox. No more quizzes, just questions. You're done.